everybody to the Learning Lab event on connecting with Latino communities on diabetes care. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the BRIE Collaborative Program in the implementation of the reports into practice and also support the Foundation's health equity work. Today, we are excited to have each of you join us and engage in this event as we work to explore how the BRIE reports and the Foundation's social need and health equity reports can be implemented into the healthcare ecosystem and ensuring equity is centered within our implementation efforts. As we begin, we have a couple items we'd just like to review. Please place any questions you may have for our staff or our speaker in the chat box. Our staff will be reviewing the comments to help answer them or raise them to be asked during the Q&A portion of our event. Please ensure you are on mute prior to starting to help minimize any disruptions during the event. We are recording today's presentation, and our speaker's presentation and Q&A portion will be accessible after the meeting via our website, and those who signed up to attend today's event, you'll get the link to the recording too in an email after the event. The Learning Lab event has been approved by WSMA for individuals to attain CME credits. The CME credits are available to claim for individuals who are attending the live event only. Unfortunately, we are unable to provide CME credits for individuals who watch the recording. To receive CME credits, please complete the post-webinar survey at the end of this presentation. Once you hit submit, you'll be taken to a page that you can click on a link to access the form to fill out to claim your credits. And we'll follow up with you via email after that. No one in control of content for today's presentation has indicated a relevant financial relationship with an ACCME defined ineligible company, also known as commercial interest. All clinical content presented will be evidence-based and unbiased. The agenda for today's event is we'll provide a short introduction to the BRIE Collaborative, hear a presentation from Dr. Leo Morales. We'll have some time for Q&A with our speaker, and then some dedicated time to engage with peers and connect with them across the healthcare ecosystem in a facilitated small group discussion. And finally, we'll come back as a group to wrap up and close the event. As a brief introduction to the BRIE Collaborative, it was developed in 2011 by Washington state legislation so that the public and private healthcare stakeholders would have an opportunity to identify specific ways to improve healthcare quality, outcomes, and affordability in Washington state. These stakeholders are appointed by the governor, and collaborative members represent public healthcare purchasers for Washington state, private healthcare purchasers, health plans, physicians, and other healthcare providers, hospitals, and quality improvement organizations. Each year, our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. Once a topic is identified and chosen as a focus for the next year, the BRIE Collaborative forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within the healthcare ecosystem to improve the care for the topic. In 2023, the BRIE facilitated a work group on diabetes care and developed a report that was published in January 2024. An example of a guideline from our diabetes care report, and one that will focus on today's presentation, is we recommend to host health fairs and our community-based screenings where glycemic testing is provided. We also recommend that if providing community-based screenings, that we develop a referral pathway for individuals that screen positive to connect with the appropriate level of care and to help them establish a PCP. We also recommend that partners with external community-based organizations and host screening for prediabetes and diabetes. Today, we'll hear from Dr. Leo Morales how Adios Covid has collaborated with community-based organizations to provide glycemic testing for Latinx people living in King County. Adios Covid medical staff work in partnership with the CBOs to meet the community members where they are at, provide them with culturally appropriate and linguistically relevant care. They also support the person and become connected to care, such as at the UW LatinX Diabetes Center. In his presentation, Dr. Morales will tell us about Adios Covid, their work to support the community in addressing concerns about diabetes, and lessons learned in providing care. The learning objectives for the Learning Lab today are to identify how a BRIE or Foundation for Healthcare Quality Guideline can be implemented into practice, recognize how social drivers of health can impact a person's overall health status, how we can plan or modify strategies to center health equity into quality improvement initiatives, and also how they'll provide an opportunity to engage with peers working throughout the healthcare ecosystem who are in attendance today. I'm going to stop sharing for a moment. I'm going to allow Dr. Morales to come forward, and as he works to share his slides, I'm just going to provide an introduction. Dr. Leo Morales is professor in the Division of General Internal Medicine and Assistant Dean with the Office of Healthcare Equity at the UW School of Medicine. He also co-directs the Latino Center for Health, an interdisciplinary research center committed to advancing the equity and well-being of Latino communities across Washington state. Dr. Morales received his medical degree and master's degree in public health from the University of Washington and a doctorate in policy analysis from the Rand Graduate School. He completed residency training in primary care internal medicine at San Francisco General Hospital, UCSF, followed by a primary care fellowship at UCLA. Dr. Morales's clinical practice focuses on delivering comprehensive diabetes care to Latinx patients. His research and interests and administrative duties focus on reducing health disparities and advancing health equity. Dr. Morales received a Washington State Medical Association Grassroots Advocate Award in 2021 and the Washington State Public Health Association Secretary Award in 2023 for his work in advancing community health. We are so excited to have him with us today, and I will pass it off to Dr. Morales.
Well, thank you so much, and thank you for the introduction. I'm super excited to be here today to talk to you about this work we've been doing for the past several years. And, part of what I'll have to do today is explain how I'm moving from COVID-19 vaccines to screening for diabetes and other cardiometabolic health issues. But that's the journey I want to share with you today. So as I was introduced, I'm Leo Morales, and a partner in this work and really co-founder of the Adios Covid project is Frank Martinez, who's a guest faculty with the iSchool, the information school at UW, and is an individual who has done a lot of work in the tech sector. So it's been an interesting partnership and one that we've really enjoyed, at least from my point of view, and I think from his as well. So I'll tell you a little bit more about him as I go along. So one thing I was going to ask, if there are questions in the chat, please feel free. Somebody, Emily, maybe you could just let me know, because I can't see what's going on there.
Absolutely, we'll help you with that, and we will have some time at the end for Q&A for everybody too.
Great. So for today's agenda, really, I want to share with you what we've learned through Adios Covid, and then how we've moved from working to vaccinate individuals, Latinos in our state, to screening for cardiometabolic health. A little bit about our center. So the Latino Center for Health has been the university sponsor for Adios Covid. We're a state-funded interdisciplinary research center at the University of Washington. And we conduct community-engaged research and capacity building. And by that, I mean workforce development, really through partnerships that we've established over the years with community stakeholders. Our focus is really to improve the health and well-being of Latino communities in our state. And we are administratively housed in the School of Social Work. So that's a lot of words. I want to say a few comments about some of this. The fact that we're state funded, I think, makes us somewhat different from a lot of the research centers that are at the University of Washington, in the sense that our primary sponsor are the citizens and residents and individuals living in the state of Washington through the government. And therefore, we feel and endorse the notion of our obligation is really to serve the communities in our state. And I think that's different in many ways, in the sense that we're not simply chasing grants. Grants are great, but they tend to come and go, and sometimes leave communities without the kinds of services and attention that they might get during a particular project. And I can certainly talk more about that, but I think the role of grants and sustainable funding for the kind of work you do when you're doing community engaged research, I think is an important consideration. So what is Adios COVID? So Adios COVID was a project that was established really when Frank Martinez approached me in the summer of 2020, soon after the sort of announcement of the pandemic. And he was interested in collaborating on the goal of vaccinating Latinos in our state, and we really made that our North Star. We decided that we wanted to vaccinate all Latinos in our state, but we wanted to choose an approach that would reach Latinos who were not being reached by the sort of pathways that were established at the time. And at that time, you know, the focus was through mass vaccination centers and through healthcare providers. But there are many Latinos and others who in our state who are not connected with healthcare systems and are not particularly trusting of large governmental efforts like the mass vaccination sites. That led us to a strategy that was really to work with communities and those in communities that had connections with these individuals. As I mentioned, our center has supported this project. We also, the other thing to note is how we developed resources for this work. A lot of it was in-kind resources, and by that I mean is the lending of resources that were available through other entities. And here in particular, the state health department was super important through a group that was called the VAX Center. And this was a coordinating center for vaccine action that brought together public and private entities to solve the problem of stemming the tide of the COVID-19 pandemic. There were other groups we worked with, but that was particularly important. You know, I just have a few slides to share with you about the pandemic and, you know, why it was important to focus on this community. I'm sure many of you are aware, but Hispanic and other individual and people of color were disproportionately adversely impacted by COVID-19. And there's more to say about that. I will say more about that in a few minutes, but you know, these are just some statistics. The stories that they tell are really about vulnerable communities with fewer access to resources and under vaccination, lack of PPE, and lots of other factors related to living conditions that resulted in higher rates of infection and complications due to COVID. That was national data. This is from our own state. This is from the period of about 20 to 22. And you know, what you can see here is ratios for Hispanic to white rates of of infection in the first set of first bar, hospitalization rates and death rates. And so you can see the disproportionate impact here. If you look over to the right, we have age-adjusted death rates for different racial ethnic groups, and again, you can see the disproportionate impact that COVID was having in these in different communities in our state. This is actually more recent vaccine data, and you know, the numbers have changed a lot. And here there are three sets of bars. The first are for the percent who have have had at least one vaccine. Completed is usually 2, but could be 1 if it was a 1 vaccine series. And then the up to date is really having the most recent booster at the time of this data. Early on, you know, there was a big push to vaccinate communities of color in particular, or inclusive of Hispanics or Latinx people. And you know, so there was a lot of progress that was made to get these numbers to where you see them here. However, you can see overall there's been a decline in booster uptake, and the disparities again are emerging. So at this particular point in time, you can see that you know, the LatinX vaccination rate is approximately a third of what it is among the non-Hispanic white population. And finally, I just want to bring your attention to the complications associated with COVID. So, you know, COVID we may be past the pandemic phase, but there's a legacy to this pandemic that persists, and that is long COVID. And it stands to reason that in a community, in a population of individuals who had higher rates of infection, lower rates of vaccination, higher rates of complicated COVID, you would also see higher rates of long COVID being reported. And in fact, you know, this is data from the Pulse survey. The census has been running for several years now, and for Washington State. And this is at 2 points in time. And you can see that among the groups that are represented here, Hispanic or Latino people are reporting the highest rates in the state of persistent symptoms of 3 months or longer associated with a COVID infection. So I started to mention a little bit about our model. So how we organized ourselves. So we were, you know, the Latino Center and Adios COVID. And what we did was we were able to work with contracted vaccinators, currently known as the Caravan program. And one in particular, Birdseye Medical, which is located in Olympia. So the state made it possible for us to work directly with Birdseye. And what we would do is coordinate with CBO partners through our network, through the Latino Center's network of CBO partners, and to coordinate events for, you know, pop-up vaccination. And as we went along and did this work, our network of CBO partners grew to the point where we were able to arrange for these kinds of opportunities really throughout the state. And I'll share with you more. But I think it's really important to say, you know, it was through this collaboration with the state. And again, it was quick. So it wasn't a grant we had to write and wait for approval. We were able to move very quickly, and I think the other thing is we didn't have to worry about how to fund our contracted vaccinators. That was an arrangement that the state took care of, and for us it was really to coordinate with CBO partners. So and you know, we can talk a little bit more about roles, but basically what we did was provide information to CBO partners, help them organize their events, and then and bring them together with the vaccinator group. Typically Birdseye, but there were others. Our initial focus, actually preceding pop-ups, was really to develop a vaccine locator app that we shared through social media. And what we wanted to do at that point in time, it was hard to find vaccines, and vaccines were being you know, it was difficult to get in certain communities to find them. And so Frank, through his work with other tech developers, had a Adios COVID app that allowed individuals to, through SMS texting, identify locations and types of vaccines available in their own zip code. So that was one of the first things we did. Then we started coordinating pop-ups. We were interested then to help people test. And so it was adding to that the distribution of rapid tests. And with the advent of treatment, Paxlovid and Molnupiravir, it was really about getting people access to care. So the vaccine, I mean, the treatment itself was free of cost, but people needed to be assessed and prescribed these medications within 5 days of the onset of symptoms. And so that's a real challenge if you don't have insurance, and even if you have insurance, if you don't have established care with a PCP. And so we stood up a pilot that became adopted statewide. I'll share the model with you in a minute. We also began to add other vaccines to what was being offered at the community events. So flu vaccine being one of them, but childhood vaccines as well. How I have strong views on how community should be engaged in research. There's often this discussion around increasing diversity in clinical trials. And when I hear that, what I hear is, not having a relationship with a community. How can we get these people from a community to participate? I think the paradigm needs to change. I think you have to start with engagement and stay with a community and then build research. And the long COVID research we've done is an example of that. It really followed on to a lot of work that was done in communities beforehand. And then it was a simple task to engage in this kind of work. And then finally, it's been about health screening and connecting people to care, because we saw that it wasn't just COVID that people needed help with. There's a lot of unmet medical need out there. And so the move was, how can we innovate on health screening? Here's a little timeline of our sort of evolution. Starting, early 2020, launching the program with the vaccine locator app, then moving to offering pop-ups, test distribution, test to treat, adding other vaccines, long COVID research, and then and most recently pivoting towards doing cardiometabolic health screening. So most of the community engagement in the part of getting individuals to come to vaccines being offered or screenings is really the work of the partner community-based organizations. These are the individuals who know their communities, they're in their communities. From where we sit, we certainly can't do that work. And so we rely on our community-based organizations to bring together the community around the offerings, and then we help support those. We have, with some success, done direct advertising, marketing for our events through social media, radio, and TV. But I think the primary way that people learn about these events and the reason that they come is because of the community-based organizations that we work with. We've also worked with faith-based organizations, and I have already mentioned the DOH and accountable communities of health as well. Some work with the private sector. We partnered with the Mexican consulate, and we partner with elected officials as well. These are some of the partners that we've worked with over the last several years, just to give you a flavor for who our partners are or have been. Again, we focus on the Latino community. We serve anyone who comes, but that's the focus of our center. And so you can see here the names of various organizations of different kinds. So we have a Chamber of Commerce here, Hispanic Chamber of Commerce in the Tri-Cities. We have Greater Health Now, which is an ACH, and many other organizations, including a Catholic church and others. So just to give you a sense of what we do, who we do it with. I think of note, these are not healthcare providing organizations. So this is just to show you on a map where our events have been, our partnerships have taken us to. And so on this map, these stars represent locations where we've been with vaccine and screening events. There's more to add to this, but this gives you a flavor for our sort of statewide engagement. I do want to note that we have not done a lot of work on the Kitsap Peninsula, or none really. And that's something we're thinking strategizing around, because I think it's a area of high need. How our events are co-located with the population of the Latino population in our state is illustrated on this other side. So there's two ways to represent the Latino population in our state at the county level here. One is by numbers, counts of how many individuals identify as Latino. The other is as a share of the population. And you can see the largest numbers are on the west side of the state, but the communities with the highest share of Latinos is located more in the central part, and going down towards the Southern Columbia Basin area and Yakima Valley. These are just some images from doing this work. This image in the upper left-hand corner is a photo of one of our students. So we've had summer interns. So this particular student was at that time an undergrad and is now in graduate school in epidemiology, and had not really done anything clinical, but learned and was really excited about being able to screen people for diabetes. And that was in Walla Walla. So we were at a vineyard, and the vineyard had provided us with space and given employees time to get screened. These two photos in the middle here are of South Park, and I thought what was great about this event is it was really multi-sectoral. So we were offering vaccines, but there was a food bank present, and there were other sorts of community organizations and this is not unusual at health fairs, but just for those who are not that familiar, I wanted to show that. And this one down here is actually last weekend. We were in Everett, and this was at a Mexican market, and we were there with Birdseye. We're kind of in the background here, but we just set up tents. It was a beautiful day, and we were screening. What does the test to treat pilot look like? Sorry. This is just kind of to give you a sense of the workflow. We started, this was really our first sort of step into how can we utilize telehealth? How can we combine this work in the community with telehealth? And so there was a process. It required online scheduling, but the key points here were there was no insurance requirement. So the state sponsored this care. And so for those who were able, and we tried to help them navigate too, so people are given instruction sheets, information sheets about how to access this care along with test kits. Because, we weren't testing, we were offering test kits when we needed to give people information about how to get a hold of a provider and give them information. It's fairly complicated, right? You have to have people understand it's really important to, once you test positive, not only to isolate, but to, talk to a provider if you have chronic conditions. And, there's a lot of chronic condition in this community. And so it was like, if you're in doubt, call. But I think for us, it was a learning lesson in that, I think that, given our development of an app, given our marketing via social media, and we could talk more about what we did there, and then use of telehealth for prescribing of Paxlovid, all of this to me is ways of bridging this gap between our healthcare system and community. How can we continue to leverage these new technologies that actually emerged during COVID, right? They existed before, but they weren't used in the same way. And so I think this has opened a new door for doing this kind of work. So I was going to say a little bit about long COVID. So we did conduct a long COVID study. We're still analyzing data from the study. It was completed earlier this year. But this is just to show you how a project grew out of our work on COVID. So, our two partners in this research that are the community-based providers in this case were CMAR and Yakima Valley Farm Workers Clinic. The Allen Institute was really interested in doing more work in the community, and so they supported our research along with the long COVID clinic at UW-Madison. And what we've learned, some of the key takeaways from this work are, 41% of the 1,500, these were all Latinx people who responded to our survey, 60% in Spanish, 41% had reported that they had symptoms consistent with long COVID after infection. 38% reported symptoms, ongoing symptoms at the time of the survey. We asked about the impacts of long COVID, and we saw significant impacts in multiple domains of health, so physical, social, and mental well-being, all being impacted. And women were disproportionately impacted. So we found that Latinos, those who were economically vulnerable and middle-aged, were the most impacted. They reported the highest rates of symptoms. And that should be very concerning, simply because of the age of middle-aged individuals, their responsibilities, and their the fact that they may be experiencing fatigue and lack of wellness has multiple effects in the families and communities in which these individuals live. And these are pretty high rates. So community-based cardiometabolic health screening. So as I mentioned earlier, we saw that there are many untreated and undertreated individuals with cardiometabolic disease and risk factors in the rural and underserved communities where we've been doing the vaccination clinics. And so the notion is, let's not stop with vaccines, let's expand. And so that's what we've been working on. These are just some numbers to help understand the burden of diabetes in Washington State. This is really an epidemic. I mean, it's just the numbers and proportions of individuals who are either diabetic or pre-diabetic is extraordinarily high. And many of them are untreated, undertreated, or undiagnosed. And so this is something we really, and this is particularly true in the Latinx community in our state. So these are some numbers that illustrate that fact, but only tell, don't tell the stories of individuals. Part of what, I think people don't realize is that diabetes and overweight and obesity are huge problems in Latin America. So diabetes is now the leading cause of death in Mexico, higher than cardiovascular disease, higher than cancer. And more than 80% of the Latinx population in our state is from Mexico. To me, this is just quite surprising and astounding, because when I started my career in health and did some research in Mexico, we were investigating malnutrition 25 years ago, 30 years ago. And now the issue is diabetes and obesity. So there's more to this than just living in our state. It's because of the population we have here and where many of the immigrants come from. If we look in our own backyard in King County, over on here you have the density of population of people of color in particular. And I mean, look, this is where Latinos live by and large in South King County. So just to orient you, this is Lake Washington, Mercer Island. This is Puget Sound. And this is where there are higher rates of obesity, of diabetes, unmet medical need, and lack of medical insurance. So kind of a setup for poor health and well-being. So when we do this is what we're trying to solve with our screening. So we sit between public health, work, community-based population screening, and traditional healthcare, and we're trying to bridge this gap. And we think we can do that by leveraging our experience working in the community, using health tech, and the network of community-based organizations that we work with. So we're really trying to fill this gap. I just can't say enough about how important I think it is to so I work in a healthcare system, I work at UW Medicine, and I know how focused within our organization we are on the patients that we serve. And I'm always thinking about the people we don't serve, who are not patients, but need attention. And I think all healthcare organizations tend to be focused that way for lots of different reasons. It excludes a lot of people. So how can we bring people in? So our work in this space, our goals are to continue to strengthen our relationships with the CBOs that are serving Latinx communities in our state. What we're doing is screening in English and Spanish, 18 years of age and older, for obesity, overweight, prediabetes, diabetes, and hypertension. And we do that with I'll share a little bit more about what we're doing in terms of testing. The form you see here is what we give people, and we have one in English and one in Spanish at the end of their engagement. So we let people know what their A1C is. We compute a BMI, as imperfect a measure as it is. But we help, and it's mainly, well, I can say more about what I say about that, but it is helpful to give people a holistic picture of how all this works together, right? So metabolic health is a function of all these different metrics, including cholesterol and blood pressure and blood sugar. So we give some advice around cardiometabolic risk factors and how to mitigate them, which is really, getting care if needed, and then prevention. And that's really through physical activity and nutrition. And for those who need care, we're wanting to link people to telehealth as a bridge to primary care. So we do an intake. We test an A1C. So we have so in this image up here, you can see our A1C machines. We have a stadiometer here. There's a scale attached below, blood pressure going on here, and counseling over here. And what we want to be able to do is get people to care for those who need it. And I'll just give you one story. So at the Everett Clinic, so let me just say more, when we do this, we find a lot of hypertension. Some people are under treatment. A lot of them are not. We find a lot of overweight, and we find a lot of pre-diabetic A1Cs. Some in the diabetes range. Most of those who are in the diabetes, in the upper levels of A1C, anywhere from 8+. Some are treated, some are not. They're not in good control. And often they will say they either have not seen a doctor for a while, or they have a hard time accessing their care. So, you know, primary care is overwhelmed, I think, is my impression in the state. Wait times to get in as a new patient are months. And even for those patients who need sort of more intensive care, it can be a very slow process. There was a woman at this event up in Everett who was pregnant and had an A1C of 8. And you know, that is a very dangerous situation. And she had a provider, but had not been, I guess, had something like one prenatal check. But you know, that's a scary situation. So what we try to do is take information, and I'll talk a little bit more about how we try to link people to care. You know, we try to call people, and then we have to navigate a financial assistance program if people don't have insurance, and frequently they don't. So we do that with help from social work at the LatinX clinic. And then eventually the idea is to get somebody on, you know, for a telehealth visit with us if they can't come in for in-person visits. So because we're statewide, you know, we can't offer in-person visits to all of the people that we screen. But I think at the very least, if we can start providing an assessment, you know, and some testing and and a prescription if necessary, you know, we can start people on the road to treatment and then hand them off to primary care closer to home. Understanding that may take a while. So this is just an event. This is in Pasco last summer. And he was the gentleman here. I probably shouldn't say, but anyway, getting his blood pressure checked, didn't know he had hypertension, and you know, was going to pursue treatment with his doctor afterwards. But this was at a farmer's market. So I'm going to end by just sharing a little bit about the LatinX Diabetes Clinic. So we're located at SLU, South Lake Union. We're co-located with the Diabetes Institute. You know, we're part of it. And you know, it's not the perfect location for community access. However, in some ways it works well because there's a lot of transportation routes to it. But I think what makes it special for the people we serve is that we are bilingual. We're able to, you know, myself and Lorena Casas Wright, who's the medical director there, are Spanish speaking. We have Spanish speaking nurses. We have Spanish speaking front desk people, patient services specialists. We have now developed a opportunity for social work students to work there, which brings social work into our clinics, and they are Spanish speaking. We have Spanish speaking diabetes educators. And we have a financial assistance program at UW Medicine that allows low-income patients to access care and not just see us, but also receive treatment. You can follow this link to get more information about our clinic. So I'm just grateful that we've been able to do this at UW. I think our patients love it, and we do the best we can to help them, you know, manage their diabetes. So let me stop there and answer any questions or take any comments or discussion.
Thank you so much. That was so informative and so interesting. I really appreciate you sharing your work with all of us. If anybody has any questions for Dr. Morales, please either place your questions in the chat or you can raise your hand. But as we're waiting for a question to come in, I just had one for you as you were speaking. You spoke so eloquently about your relationships with these community-based organizations and the significance of the community-based organizations. I'm curious, as you were working to design Adios COVID and kind of coming from this research health system space, How did you work to foster and develop those relationships with the community-based organizations?
Okay, so I have to acknowledge the work of the other co-director of the center here, Gino Eisenberg. So I joined Gino as a co-director, but Gino had been working in the community. He does a lot of mental health work for quite a long time since he joined the faculty at UW. And really the way he established his partnership and relationship with a lot of these organizations, the ones that we started with, he got in a car and he drove around the state and he went to meet people without an agenda. He just went to introduce himself and share what he was interested in working on. And through those sorts of conversations, developed relationships, which led to other relationships. And and the other thing I'll say is it's not about coming in for a research project. It's about going to see how you can help and introduce yourself. And I tell you, people, we get a lot of there's more demand than we can meet, is the way I would put it. And once people see what you do and if they like it, they want more. And that's the way it's happened. So over the course of the pandemic, it grew a lot, but it started with Gino's work in the community, and it really started with him. And I'll say, in academics, that's not always a valued approach, but it was his approach. And he said, well, this is what I do. And so he went and did it. And so, kudos to him.
Thank you. Marissa, I see that your hand is raised. If you want to come off mute.
Hi, can you hear me?
Yes.
Okay, great, thank you. I'm a population health nurse. I reach out to KP Latinx members who have an A1C of 8% or greater, or who have had more than 1 year of not having the labs processed. I was interested in the data that you found about middle-aged women with who lack care or not even know whether they have diabetes or not. And I was wondering if your data found out, is that because they're taking care of the family, they lack insurance, or they're not making time to seek healthcare because they're busy taking care of their families?
Yeah. So the data I showed you was actually on long COVID, not diabetes. But I take your point. Yeah, our research has not been into why or if Latinx women are less likely to, control their diabetes. So I don't really know what to say other than the fact that it would make sense to me. And I see it in our clinic. People are just, social determinants of health are a catchphrase for having a lot of difficulties going on, whether it's due to income or employment or housing or food. And when those kinds of issues come up, it's, hard to make your way to the doctor. I do think telehealth, we use it in our clinic, and I think it's effective. But people just need to be sort of helped to navigate to it. So I tell a story about a patient. One of my Latinx patients came in, and he works up in Snohomish as a cement worker, and so he had made his way down to us at SLU, and we were having our initial visit, and he was holding his phone in his hand as we were talking, kind of like over here by his chest, and I didn't know what that was about, but we were chatting, and so then he was expressing to me the difficulty he has in getting to the clinic. So I said, well, have you ever used something like, video conferencing, telehealth? And he goes, oh yeah. And he takes his phone and he turns it around and he shows me it's his wife. She's on Zoom from Mexico City. Okay. So he knows exactly what I'm talking about. And he just hadn't connected that you could use that same approach for healthcare. And so we've been using that intermittently, right? So he doesn't have to come down every visit, and we can do a lot. And if you combine that with CGM, with continuous glucose monitors, you have a lot of data. And so you can accomplish a lot with telehealth. So I think the new technologies like telehealth, CGM, and all the other sorts of remote sensing that's now available, and increasingly so, movement data, blood pressure data, blood glucose levels. I mean, you name it, there's a sensor for it now. We can do a lot more in the community without asking people to come in. And I think that's where we need to go.
Thank you.
I'll say one more thing about that. It's super important that we not make this technology only accessible to the privileged. I know through our clinic that everyone in our clinic can use it. We just have to make it accessible to people.
I just have one more question. Oh, go ahead. Actually, Kate, you can ask your question.
Okay, if I'm going over, cut me off. So I'm in Whatcom County, and I see that the Adios COVID hasn't been in Whatcom County. I'm not with the clinic, I'm not with the community-based organization, but I'm connected with folks in our community that are in those roles. And one of the conversations we've had, I've just been in my job a year, but it's come up twice already, the idea of hosting a health fair and the ethics around it. Most importantly, what we do when we're screening folks, what we do with the information that we're screening, and that comes down to the referral. So a couple of things. Am I hearing you say that there's a possibility, and you and I can talk later about what that looks like, to refer to UW telehealth if we uncover some of that?
Yeah, so I agree with you. That's the ethical problem I've had with health fairs too, is you go and screen and you tell people, well, you're diabetic. Good luck. Go see your doctor. And that's like saying nothing, right? So we need to connect people with care. That's the thing we need to do. And so we can accommodate folks through the Latinx Diabetes Clinic, through telehealth. I'll just be honest, we're just developing this, and it's not an easy process because it requires back and forth. It requires getting financial assistance information communicated and approved, and then we can. It's not so much about having the interaction with a provider. It's about the medications and the testing that has to happen afterwards. But that's where I want to go. I want to be able to connect people. The idea is, let's start with a, and it doesn't have to be care. So, part of it can be, you need to talk to a medical provider. But it could also be, let's think about the people with pre-diabetes or who simply need to increase their physical activity level. What programs can we connect people with that will help them make the changes in their life to become more healthy? And they have to be culturally appropriate. They have to be culturally tailored. They have to be in the language that people speak. And you can't talk about nutrition unless you talk about the foods people eat, right? So I do believe there's some of that in the community, but not enough. And so it's about connecting people to those resources and encouraging them to take advantage of them. So the answer to your question directly is yes, we have a route. We have the ability to connect people with care at our clinic. And for those who don't have a source of care, we're going down that route.
Thank you. I'd love to be a part of the solution.
Yeah.
Well, thank you so much, everybody, for your questions. We're going to transition to the next portion of our webinar today. We're going to do breakout rooms in small groups with a facilitator in each to kind of continue our conversation and have the opportunity where you can connect with each other within this space and learn more about what all you were working on and things that you are seeing in the space or in your own spaces, and see if we can support one another as we are working to support these communities. So I'm going to open up the rooms and ask that you all kind of join one. If you're having difficulty joining, please let us know, but I think you should be able there should be a button that popped up on your screen, and that will allow you to join.